welcome to Dr. Kendall, who woke up very early to do a faculty lecture for us all. Thank you, there we go.
All right, I'm really sorry it's going to get very dark in here to the post-overnight people. This is a test. All right, so this is like when you're sitting in a tape review and you fall asleep on the couch. So I'm doing late pregnancy ultrasound. It's actually not just third trimester, it's second and third trimester, basically anything starting at about 18 weeks and beyond. I did it about 2 years ago, so this is probably new to half of you and to some of you who are seniors. So part of the pitch is maybe trying to justify why we're going to take a little conference time to talk about this and why it's something that might be good for you guys to use. When I first did this, I ran it by one of the senior residents, Brian Jarrett, one of the senior residents, who he's pretty ultrasound savvy and had a little skepticism about whether or not this would be worthwhile. I think his quote was, "It doesn't really fall into my purview." He then graduated, went on, he did his global health fellowship at Mass General, and emailed me from Nepal asking me for the lecture because he was going to teach it there as well. So I think if you're going to practice medicine with a passport, this is something that you might want to have a little bit of familiarity with. And I think if you're just going to practice medicine sort of anywhere in our setting, it can be helpful. It's a nice toolkit to keep in your back pocket. And we'll sort of weave that in a little bit as we go on. I'm obviously going to show you how we do it. Second and third trimester ultrasound can be bewildering and very extensive. We're going to keep it very simple, really sort of binary approaches to things. We'll go over a couple cases. Some of them are real, some of them that our residents have experienced here. And if you remember last time, we didn't know your flags. So these are all the Caribbean flags. Maybe two-part, one to maybe why don't we embrace our immigrant communities, as well as more pragmatically, Labor Day is coming right around the corner, and you need to know your flags for Labor Day. So brief review of last time. Top left. Okay. These were all easy last time, so they got a little harder this time because everyone got it. Second one. All right, that's a nutmeg on the left side. Bottom left. All right, and top right. Trinidad. Middle right, a little harder. Guyana, nice. Bottom right. All right, cool. So speaking of Haiti, Haiti, bottom right. Cool. This is sort of where this got started for me. I worked on a project with Emetics in the Northeast Department. So up here, Northeast Department is where you fly in capitation, and we worked in hospitals in Fort Liberté and Willamette. Emetics has had a long partnership with hospitals there and some of the providers. They got some free ultrasounds and they wanted to basically develop a curriculum. The providers there were very interested in OB ultrasound. We had to learn a little bit in order to sort of give them any kind of meaningful education. So the mastermind behind it was a classmate of mine, Nia Mayam, Danica Gomes, who actually worked in Haiti for a couple of years after she graduated. And is now working at CDC. I think the last I heard from her, she was in Congo, I think working on some Ebola stuff. And we also took Ben Kaufman with us, one of the senior residents at the time. He's a white boy who speaks fluent Creole. He's able to basically banter and crack jokes in Creole, which is sort of the marker for fluency. Danica also speaks French, which got pretty far there. I spoke some Spanish, which I was able to communicate with some of the physicians. Many of them work in the DR right next door. So some of the evidence behind sort of supporting why we can teach, or why teaching ultrasound in developing countries. The first evidence that actually showed mortality benefit was teaching midwives, mid-level providers, nurses, and some physicians in rural areas. A lot of their training courses were weeks long with a lot of QA. And these were some of the first things that really started showing mortality benefits with use of ultrasound. Out of that came this last thing, which is basically the foundation for what we're going to learn, which is a simple 6-step approach to OB ultrasound. Basically screening for dangerous pathology that might actually change your management, either in a rural setting or in our emergency department. Things have kind of moved on from there. I don't think it's a stretch to make an argument that ultrasound really lends itself to work in basically developing countries, low-income settings. And there's growing evidence to support its use for a variety of applications beyond obstetric care. I think we've all heard of butterfly at this point. We have a couple. There are a few things that I want to talk about with this. Primarily, the ultrasound itself. $3,000 for a decent quality probe is phenomenal and sort of revolutionary for the field. It is literally 20 times cheaper than your basic sonocyte that we all crash around the emergency department with. Images are decent, not perfect, but for the value that you're getting for the cost is pretty amazing. Second, the platform. I'm a little ambivalent about it, to be perfectly honest. I'm a late adopter of technology, admittedly. So the promises of AI, I think, are exciting to some people. I will wait and see what happens. My concerns are more about the proprietary software on there. The fact that you kind of have to pay a monthly subscription to keep your access to the cloud. I would rather have just a platform that is completely mine and not dependent on an outside company. Last, and something worth talking about, is the user, is the sonographer. So I kind of mentioned earlier that some of the studies that they did with midwives and mid-level providers were weeks-long courses. So I think the big issue for us to consider is how people are getting trained. And I think you guys experience this as well. I was recently doing a write-up ultrasound in the main ED with a couple interns, and I was staring at a gallbladder with stones, and that just jumped out at me from the screen, and it took a little while to process that image. So we've talked about this in the past. I'm not going to name names. One of our astute chiefs pointed out maybe that doing all these unindicated fraggles could have unintended consequences. And there's a downside to maybe giving some false reassurance to patients or saying like, hey, everything looks okay, you're good. Obviously, completely good argument, something that we have to think about and something that we have to balance when we're thinking about our own education, how we're training you, and how we continue to train ourselves. There is a balance in how we try to learn ultrasound. You have to do a lot of normal, and you have to see a lot of variation on normal, and pathology starts to jump out at you after that. So when it comes to OB sono, I think I have to make the argument that you guys have to do a lot of unindicated scans in order to learn it a little bit. I would make a pitch. Anytime you have a pregnant patient, if you think you can do it respectfully, responsibly, try to get a little practice. I think for the interns, when you're on OB, this is a great time. Try to get some scans in while they're in triage. All right. Anyway. Nice. So this is St. Kitts and Nevis. The green is because of the verdant foliage on the island. The red represents the struggle of freedom. The black band is a nod to the African heritage of the island. The yellow is for the abundant sunlight, and the stars are for liberty and, actually I have it in my notes, hope and liberty. All right, so a little bit on how, the nuts and bolts of how we're going to do this. So first of all, we're not going to squint at anything. We're not going to try to zoom in on anything. This is not first trimester ultrasound. We are not ruling out a topic. We are not trying to find a Cheerio or a gummy bear. We're going to do these 6 steps. And some of them are mind-numbingly easy. Fetal presentation basically is the head up or down. Is there a cardiac activity? How many pregnancies are in there? Don't miss the previous. Where is the placenta? And specifically, is the placenta over the os? Do you have a placenta previous? That's going to be management change. How much fluid is in it? Do you have oligohydramnios, polyhydramnios? And biometric measurements, which we start to traipse into some complexity there. But I got a couple tricks, and there's a way to sort of narrow this down, and they're doable. So things to consider, just purely pragmatically, patient safety, just consider rolling your patient onto the left side a little bit, get the baby off the IVC. And just make sure that they're comfortable. Patient expectations. This is a broad topic and a lecture in and of itself. I think maybe to summarize it, just be careful about the room that you're walking into. Pregnancy is met with a wide range of emotions. It can be joyful. People can be ambivalent about it, and it can be devastating. And Likewise, the loss of a pregnancy can be any of those things. So try to kind of get a sense for the room that you're walking into. Beyond that, think about how you're going to frame what you're telling your patient when you're doing it. We all know we're doing a limited obstetric ultrasound, so just make sure that that's conveyed. Tell them what you're seeing. Don't necessarily tell them things like, your baby's fine, your baby's great. So last, obviously just think about some cultural implications, especially if you're leaving the country. This is from a picture in Delhi. Basically, not everybody's excited to have one particular sector of it. On a slightly more lighthearted note, if you're a woman in medicine and you're pregnant and you're near ultrasounds, there's generally a temptation to ultrasound yourself on a regular basis. I actually tried to find the ultrasound once, and I found in room 10, there was a nurse and a PCA ultrasounding each other. They were doing a bad job. They called me in to help out. And then we moved on and got it worked out. So unbeknownst to me, so I got to take a few looks, but this happened a lot. And we were actually in the waiting room at our 19, 20 week ultrasound where we were going to find out the sex of the baby. There was a World Cup game on, we were watching that. We literally had gotten up, we were walking in the room, I got nudged, and she was like, by the way, I think we're having a girl. So that's how gender reveal parties happen in my house. Okay, so back to how we actually do this. Just start with a scout scan. There is a large abdomen in front of you. Just put a bunch of gel on it, put the probe on, don't be shy, look around. These are supposed to be moving. Okay, so let me see it. So basically, probe markers towards the head. So cephalad. This is the fundus of the uterus, cervix is down here. This is transverse, so right side of the patient, left side of the patient. Instantly, we see a couple of things. One, there's placenta here, kind of anterior and at the fundus. There was cardiac activity over here that you'll see in a second, sort of towards this direction. You can't see a fetal head. It's down in the pelvis. But in general, if you can think that the heart's sort of in the upper part of the thoracoabdominal compartment, then you're implying that this is sort of cephalad presentation, when the head is down in the pelvis. Transverse, we see a little bit of placenta over here. So we know that it's fundal here and kind of on the right side. The placenta is sort of, or sorry, on the left side over here. The placenta is sort of fundaling up on the left. We think we see a single gestation, and there's cardiac activity. So instantly, we have a ton of information here. Another scout scan of a different pregnancy. I had a lot of luck in a sagittal view, so probe marker towards the head. So you're generally going to have the fundus of the uterus on a lot of my images up here. And as we scan through this, I think this is a 15-second clip, we see placenta here, sort of fundal and posterior, baby's head coming down, cardiac activity, bladder. So that's a brief presentation. When I was doing this ultrasound, I think the kid was asleep for a while. This is her waking up. And these are her arms, sort of stretched out, pushing up into the fundus of the uterus. Not very helpful, but kind of cute. St. Vincent and? All right. Sorry. Pretty sure that the blue is the sky, not the curve. The yellow is the abundant sun. The green, again, abundant foliage on the island. This is sort of to signify that they're the gems of the Antilles, right in the middle. Okay, so we had those 6 steps. This is the first of the 6 steps if you want to do it in a really formal fashion. The first step, just to sort of run through our schematic, all we want is to figure out is the head up or down, or is it sort of a transverse or oblique line. Generally, they're in a longitudinal sort of direction. The head is either up or down. It's generally recommended to have it in a transverse view down just above the pubic symphysis. And the idea is if you can see calvarium down there, you generally assume that the baby is cephalic. I have a lot of difficulty finding things on a transverse view, and I think Maybe it stems from getting a lot more information on the sagittal view from all my first trimester pregnancies that I've ultrasounded. So in general, I like to do it with a sagittal approach. You saw this image earlier. This is a sagittal approach again. You got legs folded up here. So legs folded up here. There's an abdominal compartment here. And there's a hint of a head down there. Kind of got to trust me on this. Here's another view. Sagittal again. Cardiac activity implies that the head is down here. It's a phallic presentation. So this one we're sort of scanning across the top of the abdomen in a sagittal view. We've got legs folded down there. There's a head up here. This is actually a breech presentation. You guys able to see that a little bit? Same patient, down lower in the pelvis, very full bladder, sort of the baby's butt sitting right down at the bottom of the bottom of the uterus. No fetal calvarium down in the pelvis. So this is a breech presentation. So it's relatively straightforward. You're just trying to find whether or not the head is up or down. So the second, you don't really need this. You just find the heart and make sure it's beating. I think you guys, if you guys can do this on a first trimester baby, you will have no trouble doing it on a second trimester. So generally this is sufficient. Just get a clip of cardiac activity. You don't have to do end mode. End mode is, you can do it if you want to. Generally I would recommend avoiding using pulse wave Doppler on anybody, especially your first trimester patients. It can generate a little bit of heat. It's probably safe in small amounts, but if I have to stand up here and say it's probably safe in small amounts, then maybe we should just be avoiding it. All right, and Lucia. So this is the Caribbean. The two triangles are the pitons, which are these two volcanic peaks on the map. Okay, so this is sort of that, you know, when you're looking for abdominal pathology in kids, that the lawnmower technique, rather than sort of putting the probe where the money is, they advocate doing a pretty broad sweep of the entire abdomen in both directions. So I won't belabor this too much, but in general, transverse view, scanning through the abdomen, and all we're looking for are number of beats. And you're going to have to use your spatial intelligence just a little bit. In general, as you scan across the abdomen, most of the time, statistically, you're going to be finding signals in pregnancies. If you think you have twin gestation, the gold standard, and especially for something that you want to submit to QA or let somebody reviewing your ultrasounds who's not physically there with you, is to find two hearts, preferably get a clip, both of them beating at the same time. This is just a little bit more in sagittal view, sweeping across, transversely across the. As we go through, we find one heart every time. A couple things about the placenta, and this is maybe where it becomes a little bit more relevant to our practice. First, it's a fairly magical organ. It has a tendency to migrate a little bit throughout pregnancy. So as the uterus is kind of small before it's sort of extended up into the upper abdomen, your placenta is going to implant generally fairly low. And thanks to a process called placental trophotropism, it will sort of migrate as the uterus expands, generally following preferential blood flow. So parts of it will die off, parts of it will regenerate higher up. Which is just something to consider if you're doing an early trimester, like a second trimester ultrasound. If you have a low-lying placenta, consider the fact that this may actually migrate higher, get away from the os, and not become a problem for you during delivery. So the simple ways of categorizing our placentas when we see them are just normal. They can be anywhere high up away from the os. Low-lying is if it's within 2 centimeters of the cervical os. And then previa if it's covering the os. And that is going to be a problem for you. So back to sagittal. So this patient, we saw it earlier, has a placenta here, and in general, they're pretty easy to see. They're not necessarily on my images on this screen, but they're generally going to be a fairly homogeneous view, or they have a homogeneous sort of texture, architecture to them. And they're going to be implanted along myometrium. They're going to be slightly different in echogenicity from the myometrium. They're fairly easy to distinguish. They're also quite large, should be easy to find. Similarly here, we're getting a larger view of it now. This is that placenta that is a little bit fundal to the patient's left. So as we sweep across the abdomen, we're getting more and more of it until it becomes a little bit more prominent here. So it's safe to read on further scans, you can tell where the ending of it is, and it doesn't get anywhere near the os. Typically when they're fundal like that, they don't extend down the os. Second patient, similar fundal presentation of the placenta. This is the patient with the breech presentation. So fundal and posterior. So I don't have a lot of saved images of pathology, so I can go to Google, which is fun. So in general, this is our fundal. This is just screenshots of a fundal placenta. An anterior one, normal again. This is an anterior one that kind of comes down pretty close to the pubic symphysis. This is the baby with the cephalad presentation. Not low-lying, not previa, not really a problem. And here, even though we don't see a placenta, what we have is fetal calvarium, basically abutting the sacrum and abutting the pubic symphysis, which essentially rules out there being placenta there. So you're granted some latitude in sort of ruling out placenta previa in this kind of case. And just a reminder, and anything placenta within 2 centimeters of the os, you have to consider as low-lying, and this could potentially be problematic once you have dilation of the cervix during labor. So this could bleed. And then last, I think for your purposes, something to always keep in mind for patients, even if you're not ultrasounding them, if you don't know of a late trimester pregnancy, if you don't know if they've had an ultrasound, you want to just consider placenta previa on your list of possibilities at all times. Just to touch on abruption, it's a bit of a clinical diagnosis. You're not always going to see it on ultrasound. There are a number of things that cause it. I think for our purposes, we may see it in trauma. If someone with advanced, who is sort of beyond 20 weeks in our practice setting, if they come in with vaginal bleeding or abdominal pain that's not traumatic, they are likely going to go straight up to L&D. So for all of those sort of medical, physiologic, drug-induced etiologies of abruption, we're really not going to see them. So I think for our purposes, we're going to see a higher percentage of abruption from trauma. So keep that in mind. I think at any point, trauma is probably going to involve this patient, OB is going to be involved with this patient in our settings. But keep in mind, ultrasounding is within your purview, and give it a shot. I think for referral purposes, this is just such an easy thing to do. You might as well try it. Just measuring AFI is a pretty simple thing. So just use the umbilicus as the center point of 4 quadrants and measure the deepest pocket in each of those 4 quadrants. So there are settings. As you go through, you can do AFI quadrant 1, 2, 3, 4. It keeps a running total. So this patient has an AFI of 17. You basically want to measure the deepest pocket in each quadrant that is free of an appendage or a cord. Normal is between 7 and 20. It's a nice wide range for you. Anything less than 7 is problematic. You're probably going to see it. So my understanding of this, and from the pathologic slides I was able to look at, you really can tell. If there's no fluid, it looks bad. I would probably get OB involved. And it's sort of like when you don't need EPSS to estimate EF on an echo. You can kind of just see it. if you've done enough of them. Very similarly to that, you can kind of just see it when you're doing an AFI. Anyone? Dominica? Again, green is for their verdant foliage. Yellow is the abundant sunlight. Black is the fertile soil. White is the pure water on the island. This is a scissor parrot. It's an endangered species native to the island. And this is also one of 2 flags in the whole world with purple in it. The other one is Nicaragua. I got a lot of flag facts. Okay, so measurements. Something that makes me a little bit nervous, but this actually came in handy for one of our residents recently. So there's a whole bunch of things that you can do. Some of them are more complicated than others. We're going to stick to biparietal diameter and femur length. And it can be a little overwhelming when you're trying to find the right sort of plane to measure. I would avoid abdominal circumference and head circumference. Okay, so just as a note, this is how complicated it can be. In order to get the appropriate abdominal circumference, you have to get the portal sinus, the umbilical vein, the fetal stomach, and a vertebral body and ribs all on the same plane. Nobody in this room is going to do that. I'm never going to do that. There are ultrasound techs. Maybe they're doing that. I don't know. BPD is doable, and even crudely, I think is reasonable. So just for your own reference, this is the slice we want. We're basically just going to try to get a plane, basically taking the top of the calvarium off, if you can. So appropriate measurements are outer calvarium wall of the near wall, inner calvarium wall of the far wall. You want the falx transversely across at the level of the thalamus and the third ventricle. I never identify the thalamus and the third ventricle, but in general, if you get a sort of symmetric view like this with the falx in the middle, it's generally good enough. These are sort of estimates of gestational age at this point anyways. It can just kind of give you a ballpark idea. Femur length is actually my go-to. I think this is the easiest one to do. I got a pointer for you in a second. What you want to do is you want to get the anterior femur transversely across. It says not to include the epiphysis. Well, it's pretty hard to find that, admittedly. So basically just anterior femur transversely and measure it. Generally is a pretty good estimate. So this is kind of an approach that I use. So if you think about slicing through the fetal abdomen transversely, you come down, your cross-section is going to be here. And as you sort of fan down here to the pelvis, you're going to find pelvic bones. And off the pelvic bones, you're going to have your femur. So all you got to do is, if this is your plane here, you come down and then you pivot so that you find this plane here. And that's essentially what we're doing here. So basically, the transverse view of the abdomen, you come down, you found a pelvic bone right here, and then you find where the femur shoots off. So that's one. I'm going to do it one more time, just because I think that this is actually useful. So abdomen, pelvic bone, femur coming off of here. And then you just follow these. And then once you kind of know the general trajectory, this is what you get. This is the same patient. This is one of the next clips. Doable with just a little bit of practice. This is my own very crude version of a biparietal diameter. Falx is roughly transverse, maybe slightly askew. And matched up with dates pretty well. Femur length was a little bit off, but in general, you're allowed to have a little bit of variation, especially this far in pregnancy. Head circumference, abdominal circumference are rather crude. I challenge anybody to identify a single structure in this abdomen. I'm never going to do it appropriately. Okay, so to review, all we're really doing for presentation is whether or not there's cephalic or breech. Sometimes they are oblique or transverse, but generally cephalic or breech. Is there cardiac activity or not? How many babies are in there? Where is the placenta? Is it normal? Is it not a problem? Or is it potentially previa and potentially very problematic for you? Is there fluid? Is there enough fluid? Is there too much fluid? Try doing biparietal diameter in female. Did she fall asleep? Carolina?
Where we go?
Oh, man. What's it? So I believe, you might need to help me out here. The red is the struggle of liberation. White is for peace and liberty and independence. The star is for Puerto Rico itself. Blue is for both the sky and the Caribbean. All right. Thanks. Thank you. Okay, so just a couple of cases. None of these are hard, but these might walk through the door and have walked through the door. So I just want you to think about it. You got a 32-year-old who's here for vaginal bleeding. She's UCG positive. No, I have not had any prenatal surgery. I have no idea when I got pregnant. You do an ultrasound. Remind you she's bleeding. You guys got any thoughts on that? Previa? Okay. So I only bring this up to tell you not to do a pelvic exam. If GYN comes down and they want to examine her without having reviewed her chart or looked or done an ultrasound, we should urge them also to not do a pelvic exam. We have had patients decompensate in CCT from this very thing, probably exacerbated by us doing exams. This was a real case after somebody sat through this lecture. So it was a little complicated. This woman came into UHB. She had a seizure. There was a lot of thought to she probably isn't pregnant. Her fiance was also female. And one would think, and I know that there was a lot of bias involved in this, but if she wasn't aware that this baby, some planning would go into a pregnancy, right? Beta was pending for a long time. They decided to put the ultrasound probe on and found a 30-some-odd week gestation. So that rapidly changed management. Patient went up to OND rather quickly. This was not a first-time seizure, head CT, or kept her. It was Beta's patient. He actually came and told me about it later, and he was like, I'm a believer in knowing some things about ultrasound.
This patient's BMI was 50.
So it was a very challenging sort of even just exam. So it was sort of, no one knew that, no one knew whether or not this patient was going to be pregnant. Last, CCT patient, MVA. Maybe some bleeding, maybe some abdominal pain, maybe an enlarging uterus. Those are some of the things that you can see with the essential rupture. So things to consider when you're working. Okay, one last review. These are the things that you should be able to do and you can try to practice. Just find the head, find the heart rate, find how many babies are in there, figure out where the placenta is, and if you're going to be dealing with a previa, measure the fluid, try your hand at measuring fetal length. Thanks. Yeah. Crazy. Anybody have questions about anything? You want to touch on anything again? Correct. Yeah, I mean, I use your judgment. I think you're the fluid's in there. It's just maybe going to be deeper on the left side if you roll them, potentially. I don't know. I would put patient safety above getting an accurate AF5. Thank you guys.